So we all know that the Latarjet is the best French procedure of the world. So to continue to improve the results, experimented surgeons developed the arthroscopic technique that I have to confess, some theoretical advantages. So I began to do arthroscopic Latarjet in 2011, and I was doing both. So in 2015, I compared my results, and this has been published last year. Outcome and patient satisfaction seems to be the same in both techniques. However, there was more apprehension with the scope, twice as many postoperative complications with the scopes, and this was mainly graft complication. And you have to know that since I published this study, I reoperated 3 patients of the arthroscopic group, so the results could have been definitely worse with a longer follow-up. So one of the conclusions could be that I am definitely miserable with the scope. I'm not the only one, actually. If you have a look to the series of the French Arthroscopic Society, or a recent series just published in June in the American Journal of Sports Med, the results are exactly the same, it seems, for everybody. Clinically, it seems comparable. However, radiologically, this is not the case. So why did I fail? I failed for several reasons. One of the first one is psychologically it was difficult. When it's 5 a.m. and you have to pick up your kids at 7, you want to do an open Latarjet because you know that 45 minutes later you will be in your car. You never know when you finish an arthroscopic Latarjet. And I never really found advantages, nor for the patient, neither for me, except that with this technique I finally improved my skills. And I had the impression to perpetually try to reinvent the wheel, because the technique was not accomplished. So every 3 months I see that even the developers were adding some tricks, and this was really difficult. And I observe a certain number of problems. Problems number one, it's graft positioning. We described with Steve Burkhardt in 2012 after an anatomic study that if you don't have your screw parallel, you will have 2 problems. The first one is your screw are going right in the suprascapular nerve. And the second problem that you can observe is that if your screw are not parallel, actually you don't have any contact between the graft and the anterior glenoid. From the scope, if you are in the joint with the scope, it looks perfect, but nevertheless, if you have a look to your postoperative CT, it's a complete disaster. Problem number 2, I remarked that the arthroscopic Latarjet is a very invasive, non-anatomic procedure. Okay, if you do an arthroscopic Latarjet, you will do 5 to 7 skin incision, and this is definitely longer than the 4 to 5 centimeter of the open one. Okay, and the second problem with the scope is that you go 5 times through the deltoid, 1 through the posterior cuff, 1 through the pec major, versus a complete anatomic approach with the open technique. Third thing is nerve dissection. I'm not afraid from the nerve, but I'm definitely afraid from neurologic complication. And when I did my thesis, I learned that nerves do not like boiling water. They do not like dissection. They do not like boiling water. The problem number 4 is you do not do the same job if you do an arthroscopic Latarjet. I'm not talking about the arthroscopic Bristow. If you have a look to this graph, on the right side you have the arthro Bristow, and you see that with a smaller graft and with an under button, actually, you have a very good positioning of your graft. This is even better than with an open technique, knowing that the guy who did the surgeon who did the open technique did not use a guide that was at that time available. In the middle, you have the arthro Latarjet, so with the screws, and with the arthro Latarjet, even the best surgeon that I know, they don't have problem with the positioning in 2%, not in 5%, not in 20%. But in more than 50% of the cases, okay? 50%, you begin your surgery and you know that at the end you have 1 chance on 2 to have the graft in a bad position. This is just unbelievable. And there is also problems with the arthro-bristow this time. One of the aim if you do a Latarjet or a bristow is bony reconstruction, okay? With the bristow, you have two problems. First of all, the direction of the conjoint tendon is not the same, and then the graft size is not the same, all bone problems. So you have some problems with the graft, graft size, graft positioning. You do not prepare as well the inferior decortication. And this is another explanation with the angulation of the screws for the 20% non-union that we observe. And this is higher than in my practice. And finally, you have some problem with the subscapular split. This is another study that we just finished with Steve Burkhardt. It's submitted. We observe that when you do an open Latarjet, you do your split with the arm in elevation and maximal external rotation, okay? This is a nice way to expose the subscapularis. With the arthroscopic technique, at least if you use a switching stick, you cannot have this position. You are generally in slight traction, neutral rotation. And if you have a look to the switching stick, there is no way for the switching stick to have the direction of the green dotted line, meaning that you are always too high when you do your split, and this explains the lack of external rotation. Problem number 5, complications do not stop after the learning curve, and you can have terrific complications like complete plexus lesion even after 100 cases in the hand of the best surgeon. George Atwal told you yesterday, yes, but it's like for the rotator cuff. For the rotator cuff, when we began, we also had problem. I do not completely agree, because when we do a rotator cuff in a 60-year-old patient, if the result is not perfect, you just have a re-tear. It's not the same that to have a complete plexus lesion in a 20-year-old patient. This is not the same. One more important thing is, I think that the prevalence of lesion of problem is underreported. I do not really believe in doctors. I believe in insurances, and I hate insurances, but anyway, they have good statistics. And this is some statistic that I have from French insurances, and I know that you don't read French, but the take-home message is, compared to, for example, the cuff, the number of complaints is quite low. Nevertheless, the rate of complaint after an arthro Latarjet is just unbelievable. This is really high, and this is due to neurologic problems. This is due to axillary nerve, suprascapular nerve, and so on and so on. I believe in insurances. Problem number 6, cosmetic appearance. For me, it's a wrong problem. None of my patients complain of the skin incision. And if it's a problem for you, you just do a small incision in the axillary fold, and the problem is solved. You will find more lesion and treat more lesion if you do it with the scope. Maybe it's like for AC joint dislocation. After AC joint dislocation, you have up to 20% of associated lesion. You have to know that most of these lesions were there previously. And I have a small pasta lesion. If one day I have a Latarjet, I don't want anybody to touch at the same time my pasta. Okay, let my pasta alone and just stabilize the shoulder. In my practice, I'm doing something like 2 Latarjet per week. I reoperated these last 10 years 2 patients for persistent slap lesion. So associated lesion is for me a wrong problem. And then myth number 8, scope is always the solution. I love the scope, but maybe this is not always the solution. All the stabilization actually do not stabilize. You solve maybe the macro instability, but you do not solve the micro instability. You just prevent further dislocation. And this persistent instability, as well as the brain sequelae, may explain the residual pain, apprehension, the impossibility to return to the same level of activity, and it can also explain the emergence of dislocation arthropathy because you have this persistent micromotion. So maybe at the end of the day, what you just need in front of the shoulder is some fibrosis, and I'm not sure that the scope is the best solution to have. In conclusion, shall we give up? No, we don't have to give up. You can do this, you do whatever you want. I'm not going to teach you what you have to do, but just know, and I'm sure of this, that nowadays there is no advantage to do it with the scope. You will have more complication, it's more expensive, more dangerous, and this is time consuming. So for me, no doubt.